evening, our ladies and gentlemen, and all the wonderful people gathered here today. Welcome to UKRIDA International Talkshow Series. We are thrilled to have you join us for this occasion. Throughout this evening, we have an incredible lineup of speakers from different parts of the globe to share their expertise with us. I am Jody Josephine, your host and moderator for today's event. Now, before we start our event, let us gather today and pray so this conference may be held smoothly. Let's pray. Dear Heavenly Father, as we gather here today for this conference, we humbly come before you with hearts full of gratitude and anticipation. We thank you for the opportunity to learn, to grow, and connect with one another in this space. We ask for your wisdom to guide our discussion and your discernment to lead our thoughts. Bless our speakers, participants, and all those involved in organizing this event. May the insights shared and the knowledge gained be a source of enlightenment and inspiration. Lord, grant us the strength to uphold the values of love, respect, and unity as we engage in meaningful conversations. We entrust this conference to your hands, seeking your blessings and guidance throughout its entirety. In Jesus' name we pray. Amen. Now let's come together to respect and celebrate our nation by singing our national anthem, Indonesia Raya. Before we begin with our speakers, I would like to invite Dr. Wani Devita Gunardi, SPMK, Director of UKRIDA, to give an opening speech. To Dr. Wani, the screen is yours.
Thank you, Dr. Jody. Good evening, ladies and gentlemen. I'm truly delighted to welcome you all to this remarkable event, UKRIDA Yes Natalis International Talkshow Series, Wellbeing on a Human Planet. I truly extend a warm welcome to Bapak Oki Wijaya, the chairman of KRIDA Wacana Christian Foundation, who have taken the time to join us today, and all our distinguished speakers from our partners all over the world, like Dr. Moon Yisi from Seattle Pacific University, Dr. Dian Kusuma from City University of London, Professor Dr. Eva Suartana from McGill University, Professor Johanna Endang Prawitasari, PhD from UKRIDA, Dr. Evans Gare, MC, and Anita Novianti, MA from UKRIDA. Firstly, let us give thanks to our God Almighty because it is by His will that we can gather today to celebrate the 56th anniversary of UKRIDA. As the rector of this esteemed university, it is both an honor and a privilege to stand before you as we delve into the pressing topic of well-being on a human planet. This remarkable talk show series consists of 4 serial talk show. First is global mental health. The second is philosophy of anti-aging medicine from womb to tomb. The third is climate change and well-being. The last is closed by interactive session of the beauty of humanity. Today, we present the theme of global mental health. This conference marks a significant milestone in our collective pursuit of knowledge and solution that bridge the gap between individual well-being, environmental sustainability, and social cohesion. Our virtual assembly today will transcend geographical boundaries and bring together brilliant minds, advocates, and dedicated professionals, all sharing a common vision, a healthier planet. Their insight, experiences, and innovative ideas will undoubtedly inspire us all to look beyond traditional paradigms and envision a new way in which we can foster sustainable well-being. We stand at a critical juncture where the action we take today will shape the future for generations to come. As we embark on this journey together, let us remember that our efforts here are not confined to the realm of academia or theoretical contemplation. The knowledge we gain, the ideas we generate must pave the way for tangible change. In closing, I extend my heartfelt gratitude to each and every one of you who has chosen to be a part for this transformative event. Your presence signifies a shared commitment to a brighter, healthier future for all. Let us seize this opportunity to learn a holistic, transdisciplinary outlook at mental health promotion and prevention from various angles, including ecological, psychological, social, cultural, political, and economic standpoints supported by science, engineering, and the art. Thank you, and I eagerly anticipate the rich and rewarding discussion that lie ahead. God be with us, and to God be the glory. Thank you.
Thank you, Dr. Wani, for your speech. We will certainly make efforts that today's event will be tangible change, Dr. Wani. Now, let me invite Pak Oki Wijaya as the head of BPTK Krida Wacana Foundation to give an opening speech. To Pak Oki, the screen is yours.
Thank you, Jody. Good afternoon, all participants in Indonesia and the Asia Pacific region. Good morning to those in Europe, and very early in the morning in the United States and Canada. I extend a warm welcome to you all to this webinar. It is certainly an honor and a privilege for UKRIDA to be hosting this international webinar on global mental health issues. As part of UKRIDA 56 Dies Natalis, or 56th anniversary, Dr. Jody and the team has organized this webinar. I hope you all will contribute and find the webinar useful in furthering the cause of helping those with mental health issues. Ladies and gentlemen, mental health awareness has grown significantly in recent years, shedding light on the complex landscape of emotional well-being. The COVID-19 pandemic, the proliferation of hoax and bullying on social media platforms, and of course the pressure on society brought about by global warming and its associated environmental issues. All this has accelerated the evolution of mental health issue in our time. I think we all recognize that someone or one of our family members maybe, or our colleague in the office, or friends in schools or in campuses have some of these mental health issues. And this has become a real concern, not just physical issue, physical problems, but also mental issues. We can find mental health problems in our workplace, in schools, in campuses, and of course in our homes. But unfortunately, many in our society still view mental health as an oddity, as an abnormal behavior, someone who is crazy. Now, I hope that, I don't know how you can include the discussion in this webinar, but I think what we need to do, especially in the Indonesian society context, is to destigmatize mental health struggles, people with mental health struggles. We have to remove this stigma, if you like, that believes people with mental health are abnormal or crazy. I think this is one way of bringing up the issues so that people will not be embarrassed to recognize if they have mental health problems. Well, I sincerely hope this webinar and the topics that you are going to discuss will explore deeper the causes of mental health issues. And through collaboration, you may share ideas to do further research and discuss approaches to address some of these mental health problems. Going forward, I hope the experts here can establish communication strategies, develop support networks to share findings and solutions that they can share together and further illuminate the issues of mental health in our society. I wish everyone will enjoy this seminar or webinar. I wish you all can find fruitful discussion and meaningful discoveries through our discussions in this webinar. I wish everyone Godspeed, and I hope everybody will come out of this webinar with something to take home and to do further studies and further research to enhance our understanding about mental health. Thank you very much. Thank you, Jody.
Okay, thank you, Pak Oki, for your speech. We will surely make efforts to tackle these mental health problems, especially during this time. Okay, now without further ado, let us delve into the main events for this evening. I want to remind all participants that there will be a plenary session after all keynote speakers at 19:30. So you can note down any questions you may have until then. However, if we are still good on time, we might go over your questions directly after each talk. You can also use the chat room to your advantage. Now, starting with our first keynote speaker with the topic of psychosocial aspects of well-being. Let me introduce Prof. Johanna Prawitasari. Prof. Johanna is a retired professor of clinical psychology from the Faculty of Psychology, Universitas Gadjah Mada. After retirement, she has been reactivated as professor of psychology at UKRIDA since March 2012. Previously, her main task was taking care of research and community service. Then she was asked to manage the Faculty of Psychology together with the Faculty of Social Science and Humanity as the Dean. After that, she was appointed as Vice Rector for Academic Affairs. Currently, she is managing curriculum and developing new study program at a university level. She is active in connecting her previous international academic network to her younger colleagues at UKRIDA. Hiking is in her leisure time is her passion since she joins UKRIDA. Let us give a warm welcome to Prof. Johanna. Hi, Prof. Johanna.
Hello, Jody. Thank you.
I don't think I can hear you very clearly.
Yeah. Oh, I think I have already unmuted. Maybe somebody muted mine. Hello.
Yeah, we can hear you, but the sound is a bit small.
Yeah. But I don't know how to put
Okay with me,
more.
Jody?
Yeah. Hello,
I'm okay.
I did how to put the sound on my device here. Is it still not clear? Hello, Jody.
Yep, I can hear you.
Okay. I think everybody will hear me too if you can hear me.
Yes.
Okay. Well, I'd like to present my psychosocial aspect of well-being. This is my view that I presented in my book. I don't know if that it's okay. And Edward has written the book on psychosocial health rather than psychosocial aspects of well-being. Slide 1, please, Jody. That's yes. Why psychosocial well-being? So many factors interwoven in determining our well-being state. In one body, we have notice system, and so that there are also notice system well-being indicators. Like, for example, notice system context of a human consisted of cellular, organic system, psychologically then organismic systems, and socially we could see the group, organization, societal, cultural, and also global system. Psychological well-being is located inside healthy body and social group. Therefore, we could say that there is a psychosocial well-being. Next slide, please. This is the multi-system context of a human body. Just one body. There are so many scientists researching the cell system, the organ system, and also the organismic system, like the individual person, animal, or plant. And I could see that above those systems, that's human-made. Therefore, we could change and also we could do something about it.
Therefore, we could create the psychosocial health to become psychosocial well-being. This is what my international mentor, Professor Sandberg, he passed away, unfortunately, in 2014. Unfortunately, I could see him in April 2014. So there are group system, family, work team, recreational team or group, animal group, and also societal system. One nation, a large part of a nation, and also supranational system, like common market, United Nations, satellite communication network, and now social media. That is so common that we use the social media now. Next slide, please. And I presented in the book that we have written that psychological and societal well-being, we present what we wrote about 5G leadership model. This is a kind of paradigm that in an organization, if you use the same paradigm, then the organization may become more well-being. Wellness is the key. And sometimes we could say well-being or wellness. We present the psychological in a micro level. We presented that proportionally we allocated personal activities in learning, working, playing, and loving. Many times our rector mentioned this, that we should make a balance between what we learn, what we work, and what we play, and what we love. So balancing learning, work, and playing, and loving is a must, so that we could become more as human well-being. And then we present the personal mastery of advanced psychological skills like emotional management, critical thinking, deep learning. And on the other hand, in a macro level, many group members could proportionally allocate personal activities in learning, working, playing, and loving. And we could see the indicator of this macro level or societal using the environment. For example, sometimes we could use the indicator of well-being from the use of garden, for example, or we use the place of recreation, for example, like the greenery of city, like in Jakarta, there are so many gardens, and it is good for now that in Jakarta, so we are experiencing pollution, very healthy, and it's not good for our body. And many group members have personal mastery of advanced psychological skills. Next slide, please. In psychological or micro level, what I mean micro is individual, personal, humane ambition. What I mean here is everything in moderation, or in bahasa Indonesia, udahari. And we could become active in cooperating and caring for others in social system. And we are thinking about social credit system that I have discussed with people at UKRIDA. So it's not related to money, but time to take care of others. And also in a micro level, we could become mature and also skillful in mentoring in our social system or in organizational system. In the macro level, many group members have personal humane ambition, and in a group or social system, we have also cooperating and caring atmosphere. And one of the most the advanced skills that we should have is mentoring as part of a group's culture. So in organization, if we have a mentor, someone who is skillful, who is respectable, honorable, and have so much experiences that could be shared in an organization, that the organization may become well-being, or the wellness may be reached by those skills, competency. Next slide, please. We present what we call 5D leadership and followership model. The basic is G1. We are skillful in learning, working, playing, and loving. So that's the basic. And then G2 is an advanced psychosocial skills, and G3 human ambition, and we could become cooperating and caring in our organizational atmosphere. And the utmost is the mentoring. I can explain furthermore in the next slide. So many psychological theories and practices could be applied to improve and maintain basic psychological well-being. So we are aiming to proportionality of learning, working, playing, and loving in our G1. We have developed the monitoring using the technology, the application, the balance between learning, working, playing, and loving, so that if the participant would like to have that applicant, you can contact me for happy in Willow workshop. And also we could improve and maintain advanced psychological skills. For example, we learn how to manage our emotion, of fear, of sadness. Sometimes people say that those are negative emotions, but to me, emotion is not negative or positive. Emotion is just emotion, but we shall manage those emotions as a human being. The negative or positive is only the evaluation of other people, or maybe shorten the mark that that's negative, that's positive. But I guess emotion can be managed, because for older people like myself, hilarious and we laugh so happily can become fatal, and our heart maybe can stop. Who knows? And also we learn how to become critical in our thinking and also deep learning in G2. Next slide, please. And G3, humane ambition. We like to aim to solve life problems, to actualize self, to contribute to humanity, and also to make a better living world in a macro level, for example. And also based on social interest, motivation is not on revenge, but seeking attention or show of forced motivations. So sometimes in an organization there is for Indonesian, sometimes we like to say something on our back rather than we talk assertively, we talk based on data, on facts. So we need to improve our social interest motivation. It's not revenge or seeking attention or show force motivation, but making the balance of how we present the positive side of us. Like UKRIDA have the motto of leads, laughing, and so forth. I forget now. And also we demand adequate effort, not too much, not too little. So we present ourselves in moderation. Next, please. And the G4, we have protective factors like building optimism and also universality of experience. We could share that we are human beings, that we have the same problem, we are struggling in our lives, and also we could present ourselves in balance, like in the first G, for example. And also we can learn interpersonal relationship so that we can give feedback. We can, as a leader, for example, we can give feedback, the facts, the behavior, and we still share the love that we have for them. And also we learn how to use solidarity with empathy, with sympathy. And there are also risk factors like spreading skepticism, pessimism, like talking behind us. That's not a good culture. And we then feel alienated and isolated because maybe we are different, we have different views, we have different attitude, and be careful what others thinking when we are different than others. But we can share love with them so that everybody could feel the love that we share. And some risk factor, interpersonal relationship full of prejudice, suspicion, manipulation, and also fragmentation. So we need to learn how to cooperate and care and developing the atmosphere based on those competencies. Next, please. And this is the last one. As a mentor, we need to show sincerity, and we create the safe atmosphere, a situation for mentee. But sometimes, as a human being, sometimes we have also some emotion related to what the mentees have done wrong, for example. And because we are sincerity, we have our own sincerity and related to them, then we could share the kindness that we have. So we show the model how to express our true self so that there will be benefits both the mentor and the mentee. Sometimes mentoring is lacking in an organization because the senior are insecure that their knowledge, their what they have could be stolen by the younger generation. But I guess the mentoring in our book, we develop sincerity, safe situation for the mentees, and also we model to express our true self so that the situation can be benefit both for the mentor and mentee. Both parties could learn from each other, from the feedback that we give and also from the feedback from the mentee to us. Thank you, Jody. I guess the time has, but I'd like to show that I have implemented the 5G leadership and followership when I work together with the Konrad Adenauer Stiftung to assist the women's legislators, legislatives. And I show them how to manage their emotion and also to become their true self in presenting their system toward their people who will appoint them to become the legislative members. And the last slide, please. This is call for action. How healthy is our proportionality of learning, working, playing, and loving? How to improve our emotion management, critical thinking, and deep learning skills. And how humane are our ambitions, and how to contribute to developing a cooperating and caring group in our social system, and how to spread mentoring mentality in our social system. Thank you very much, Jody, for your assistance. Thank you very much for listening my talk about the book that we wrote for all of the participants. Thank you.
Thank you, Prof. Johanna, for your presentation. If any of the participants have questions, I would like to remind everyone to note down your questions so we can go over them in the plenary session at 19:30. Now, I would like to introduce to everyone our second keynote for today, speaking on global health issues in non-communicable disease, Dr. Dian Kusuma from City University of London. Dr. Dian Kusuma is a lecturer in global health at City University of London, UK. His expertise includes health system assessment, health financing, health service delivery, health inequalities, and health reform policy impact evaluations, especially in low and middle income countries. He graduated from Harvard University with a Doctor of Science in Global Health and Population, majoring in health systems. He worked as a postdoc researcher at Harvard during 2015 till 2018, working in the Malaysia Health Systems Research. He conducted a comprehensive health system assessment and designed a large-scale mixed method cluster randomization impact evaluation of the enhanced primary healthcare intervention toward tackling cardiovascular risk factor. So I would like to give a warm welcome to Dr. Dian Kusuma. Hello, Dr. Dian.
Hello, thank you, Dr. Jody. And thank you, everybody. Thank you for the opportunity for me to share. And thank you for the kind introduction. Without further ado, let me start the presentation. So I will be sharing global health issues in non-communicable diseases in this session. And next slide, please. Yes. So we'll be talking about SDG targets 3.4 and then NCD and global burden. And we'll talk about mental health, how it links with major NCDs. And also I'll share with you some strategies, intervention or policies. Next slide, please. Thank you. Most of you, if not all of you, are familiar with the Sustainable Development Goals. These are the 17 goals in development globally, and all of the countries in the world are committed to achieving this goal. And today we'll be focusing on the third goal, which is good health and well-being. Next slide. And for the goal 3, ensuring healthy lives and promote well-being for all at all ages, we'll be focusing on target 3.4 specifically, that is by 2030 to reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. Yeah, so in this target, there's a non-communicable disease there, mental health and well-being as well. And then it's in terms of indicator to achieve by each country. We're talking about more, indicator 3.4.1 is that mortality rate attributed to cardiovascular disease, cancer, diabetes, and chronic respiratory disease. Yeah, so these are the 4 major NCDs. Next slide. Now we'll be talking about NCDs and global burden in the next few slides. Next slide. So this is the, so some of you, or if not all of you, are familiar with the global burden of disease with the use of disability adjusted life years, which is DALY. So this is a way of comparing the burden of disease that is taking into account both mortality and morbidity. Yeah, so disability and also death are included in here. And as you can see, this is the trend between 1990 to 2019. So this is almost 30 years, so 29 years. And this is showing you that in 1990, for instance, the share of the burden of disease by cause is almost equal, if not bigger, the incommunicable and maternal and neonatal and nutritional diseases. Yeah. But as we go along now, in 2019, the burden is much bigger for the non-communicable diseases, which is accounted for almost 64% of the total burden of disease globally. Yeah, so this is to show you the magnitude of how how the magnitude of how non-communicable disease is impacting the death and disability in the world. Next slide. In terms of the data, it shows that the NCD kills about 41 million people each year, and about 74% of all deaths globally. And each year, 17 million people die from an NCD before the age of 70. Yeah, and then so that is more than 40 million people are killed by NCD, attributed to NCD each year. So that's a huge number. And there are 4 groups of diseases that account for over 80% of all premature NCD death, and premature meaning before the age of 70. Yeah. So the diseases are CVDs, which is cardiovascular diseases, including heart attack and stroke, that is accounted for almost 20 million people annually. Yeah. And then cancers, almost 10 million. And then also chronic respiratory diseases, more than 4 million, and diabetes is 2 million. So these are the four groups of diseases that accounted for most of the NCD death. And when we talk about high-income countries and low-income countries, we're talking about the NCD disproportionately affect people in low-income countries, including Indonesia and our neighbors in like Thailand, Vietnam, Malaysia, all the low and middle-income countries, where more than 3/4 of global death occur in low and middle-income country. Yeah, next one. And so who are the people at risk, right? So often NCD are associated with older age groups. However, evidence shows that 17 million NCD deaths that happens before the age of 70 years. Yeah, so it's no longer diseases for the older age groups, but this is sort of impacting all age groups. Yeah, so children, adults, and elderly are vulnerable to NCD's factors, risk factors such as unhealthy diet, physical inactivity, exposure to tobacco smoke, and also harmful use of alcohol. Yeah. So all of these could be driven by unplanned urbanization, globalization of unhealthy lifestyle, and also population aging. Next one. Now, this is to show you the leading causes of death. Now, before the slide before, you see that in terms of global burden of disease in total, it is divided into 3 groups, and NCD shares in terms of death and disability globally account for almost 64%, right? Now within that, so this is really showing each of the diseases that causing the death and disability, yeah? And this is to show you on the left-hand side, we see the leading causes in 1990, 30 years ago. And in the middle, towards in the middle there, that's the leading causes of death and disability now, about 2019. And as you can see in the top 10, there's so many non-communicable diseases there, like IHD, ischemic heart disease, stroke, and diabetes is there. Yeah. So this is and this is for all ages. You see, if you see on the top left, that's all ages. Yeah. Next slide. Now, if we talk about the young productive age group, which maybe many of, if not most of you here is within 25 to 49 years old, and you think, oh no, maybe NCDs is not affecting us. Actually, the data is showing that is not the case. If you see here in 2019, that's towards the middle there, the leading causes of death and disability for this young productive age group is also, a lot of them are NCDs. In fact, in the top 10, 7 of them are NCDs, yeah, with all the major ones there as well. Ischemic heart disease, depressive, stroke as well, yeah, and mental health is there as well. So yeah, so this is really, this is affecting all ages, not just the older ones. Next one, please. Now, in terms of risk factors that is increasing the likelihood of getting NCDs, what are they? There are 2 things. One is behavioral risk factors, and the other one is metabolic risk factors. On this slide, we have behavioral risk factors, as you see here, that we have tobacco use, that's behavioral risk factors, physical inactivity, unhealthy diet, and the harmful use of alcohol. All of that could increase the risk of NCDs, yeah? And here are some data. Tobacco alone, for instance, is accounted for over 8 million deaths every year. This is including exposure to secondhand smoke, yeah? So if, say, for instance, the husband is smoking, and all the families, the children and the wife is also inhale the secondhand smoke, they are also, at risk of death, by this one. Next one, please. Now, the second type of risk factors is metabolic risk factors. So if someone is doing all the risk factors or some of the risk factors, it will show up in your body. It will show up in as these key metabolic changes. Yeah, it will raise your blood pressure. It will improve. It will cause you an overweight and obese. It may cause you a high blood glucose and also high level of fat. Yeah. So these are the indicator metabolic changes that we can observe in our body if somebody is doing some or all or of the behavioral risk factors. Yeah. And the top of the leading metabolic risk factors that is accounted for almost 20% of global death is hypertension, yeah, elevated blood pressure. So that is really, really, on top of the list in terms of risk factors causing non-communicable diseases. Next one. Now, again, sometimes, we talk about non-communicable diseases is only, diseases for the high-income countries, but actually the socioeconomic impact of NCD is large, and poverty is closely linked with NCDs, yeah? So the rapid rise of NCD, is predicted to impede poverty reduction initiative in low and middle-income countries. So if you are working, so for instance, with the national planning agency like Bappenas in Indonesia, or you are working with the, in the development sector, focusing on reducing poverty, NCD should matter to you because, one is the first bullet, the second bullet that is that showing that socially disadvantaged people, they can get sicker and die sooner than people of higher social position, yeah, especially because they are greater at risk of harmful products such as they smoke more, they had more unhealthy dietary practice, and also have limited access to health services, maybe because of low coverage of health insurance and all that. So they are more vulnerable, yeah? And also the third bullet there is that healthcare costs for NCD quickly drain household resources, yeah? Because, the treatment, diagnosis and everything, they are long period, lengthy and expensive. And combined with, with loss of income, it could force millions of people into poverty annually. Yeah. So this is how, you can link easily NCDs with poverty and also poverty reduction. Next. Now, this is, when we talk about at the national level, and, we can also talk about the subnational level. And this is a paper that we published together with colleagues from University of Indonesia and also Ministry of Health. And this is showing the disparity in obesity, for instance, among adults, among all districts in Indonesia. And as you see there in the first column, in all adults, that's the percent of obese adults. If we compare Papua and Java, for instance, the prevalence of obesity in Java is almost 30% higher. Yeah. So, and then also if we compare that by income, district within the quintile 5, the richer district has has a 30%, 36% higher prevalence of obesity. Yeah? So this is important for policymakers, at the national level, provincial, and also local level to plan, and then to focus their effort accordingly. Yeah. Next one. And this is another paper that we published together with colleagues at Imperial College London and also universities in South Asia. And this is to show how food environment is associated with diabetes in South Asia. Yeah, and this is showing that, and this is showing that high blood glucose it's associated with the proximity of someone with the fast food restaurant, and it's showing that in terms of the total sample, it's associated with additional 16% of odds, yeah, of if someone is has fast food restaurant in the proximity, the odds of getting a diabetes mellitus of high blood glucose is 16%. And then the second one is also diagnosed diabetes, that's panel B. and it's also showing an odds of 1.19. That is an increased odds of 19% compared to if they have the fast food restaurant in the fast food retailers in the community, in the proximity, and proximity here is within 100 meters. So this is, again, can become evidence for policymakers in how to make the environment is more, healthier in terms of food environment. Next one. And next one. Next one. And this is just to show, because we started off with SDG, and this is to show you the solid line as that's the observed probability of dying right now that we have. So that would be until 2019, I think. And then the dash line, that's the projected, if nothing is being done or business as usual. And now the dash and dot lines are the SDG target. And this is showing that if business as usual is to proceed, no region in the world will achieve the SDG target in terms of 3.4.1. Yeah, that is reducing the death and the mortality due to the 4 major NCDs. So something has to be done, in all of the regions globally in terms of NCDs. Next one. Now let's link a little bit with a major NCDs with mental health. Next. So all the major NCDs, when we that we have talked about the cardiovascular disease and diabetes and all the risk factors, smoking, obesity, and all that, there are a lot of evidence showing that they are linked with mental health, which is the main topic of our event today. And this paper, for instance, is showing a paper in 2012 published in Nature Reviews Cardiology, and showing that morbidity and mortality in patients with cardiovascular disease and depression. So if someone is having both cardiovascular disease and depression, the mortality and morbidity are significantly higher when we compare with patients with of cardiovascular disease but doesn't have a depression. Yeah. So this is how it's linked. Next one. So similarly with the diabetes, this systematic review, for instance, is published in Journal of Affective Disorders, is showing that the prevalence of depressions is more than 3 times higher in people with type 1 diabetes, or nearly twice as high in people with type 2 diabetes. So this is how they are associated. Next one. And this is another one showing the association of cigarette smoking with depression and anxiety. Next one. And even this one is the data from World Health Survey in South Asia, and then they show that the lower frequency of vigorous physical activity were significantly associated with higher rates of, so lower frequency is associated with higher risk of depression. Yeah, so that's how they link. So all of this is just to show that the huge burden magnitude of the problem in terms of the 4 major NCDs and how they are linked with mental health and depression of anxiety, for instance. Next one, please. Now let's talk a bit about strategies, intervention, and policies. Next one. So one of the main policy globally is this one, Best Buy from the WHO and partners. So these are the best buy and a recommended intervention for the prevention and control of non-communicable diseases. Yeah. So I have the link there, the title of the document there. You feel free to download and read a bit more detail. We'll discuss a little bit about what we have on the slides. Next one. So these are the lists of intervention, effective intervention. So the best buy is really effective intervention, and they are cheap. So that's why they call best buys, right? And also it adds with a smaller bullet, that is effective intervention. They may or may not be cheap depending on the context, but they are effective intervention. They also put it here for policymakers to sort of pick and choose. For instance, for reducing tobacco use, the best buy, that means that these are the effective intervention, and also they are cheap. Yeah. include increasing excise taxes, for instance, and prices of tobacco products, yeah? And also implement plain packaging and large graphic health warnings. Also ban tobacco advertising, that's also another one, and ban smoking in all indoors. Yeah, so those are the best buy. They are effective intervention and they're also cheap. Another one, if you look at the promotion of a healthy diet, for instance, is by reducing salt intake, yeah? So product reformulation, providing lower sodium and all that. Next slide. And when we talk about more about each of the four main diseases, NCDs, we talk about diabetes, for instance, some of the effective interventions are offer glycemic control for people with diabetes and also provide preventive food care for people with diabetes, yeah? And also screen diabetes patients for retinopathy and provide ways. In terms of cardiovascular diseases, provide drug therapy and counseling for eligible person, yeah? So, download this document. This is very, very valuable source of policies and, which is listing all the intervention that is needed, for an effective prevention of NCDs. Next one. This is an example of a study that I did together with colleagues from Udinus and Semarang, which is showing all the outdoor tobacco adverts around schools in Semarang, yeah, in 2018. And you see that we had a total of almost 3,500 adverts, and all of them, 87%, are medium or large, and all of them are within, most of them or many of them, 74% are within 30 meters from school. And we look again and whether or not they're higher as we go closer to school. And the evidence is showing that all the ads, on average is 45% higher, when they are closer to the school, yeah? So that's the title of the paper there at the bottoms if you want to look further. Next one. And the second question that next one. Second question that we want to answer with, no, go back. Yeah, the second question that we want to answer is whether or not that exposure is actually associated with smoking behavior. And, we did another study and it's also published and it's showing that students at schools that has a medium or high density of adverts, they are more than 2 times more likely to smoke. So this is the first evidence using geospatial analysis in Indonesia showing this strong evidence. Yeah. Next. Now this is another studies that I was involved in Malaysia. This is the prevalence. The top one is the prevalence of diabetes in Malaysia from 1986 to 2015, and the bottom one is the prevention of hypertension. So there's two takeaway here. One is that in terms of diabetes, especially, the prevalence, the increase in prevalence is rapid. Yeah. And then the second takeaway is that the undiagnosed is getting bigger. The proportion of undiagnosed. If you see the data in 2015, for instance, you see that out of the 17.4% of the prevalence of diabetes, most of them, 9.1%, are undiagnosed, and only 8.3% are diagnosed. Yeah, so that is showing how the undiagnosed is big. Next slide. So together with the colleagues in Malaysia and also Harvard University at the time, we designed something called Enhanced Primary Health Care, which is at the population level. We try to improve the screening for NCD risk, and the aim is really to reduce the undiagnosed population, because if they're undiagnosed and left untreated, left uncontrolled, they will become severe easily, and it will be costly for the individuals, the household, and also for the healthcare systems. Yeah. And then in the clinic also we do a reform, like having a family health team, and also all of the others one. Yeah. Next one. Now we did a we did a impact evaluation, which is this is the published paper, and this is showing that the intervention is showing is an effective in terms of improving HbA1c tests in the past 3 months and also other tests. Yeah, this is really showing that the enhanced primary healthcare intervention is reducing the undiagnosed in the population. Next one. And this is another population-based intervention to increase awareness among the community. We call it Happy Village Plus in Sri Lanka. And this is being done in Sri Lanka, and hopefully when the result came out, we'll be able to share more results. Next one. Yeah, so these are, in summary, the set of intervention needed to move countries forward. Tobacco, alcohol, and also effective health system interventions are important. Quality primary care and referral systems are important. Early diagnosis and treatment, and also effective screening and treatment. Yeah. Next slide. Call to action in that in your roles and settings to advocate for NCD prevention and control, including within the mental health prevention framework. A comprehensive approach for all sectors, and also actionable plans and initiatives to address NCD and promote health and equity, and contribute to the NCD agenda locally, nationally, and globally. Next. Thank you for your attention, and here are my email address if there's any inquiries beyond this event, and also potential for research collaboration. Thank you so much.
Thank you, Dr. Dian, for your presentation. So, participants, now we have finished 2 keynote speakers from Prof. Johanna and Dr. Dian. Let me remind all participants to save your questions until our plenary session, or you can make use of the chat room in the Zoom meeting. So, might not be a stretch, maybe, Prof. Johanna or Dr. Dian, if I said that if people are psychologically and socially well, the NCD numbers wouldn't be as high, maybe. Let's see. So now I want to introduce to you our 3rd keynote speaker, which is Dr. Evans Gary and Bu Anita Novianti from the Department of Psychology from Universitas Kristen UKRIDA Wacana. So Pak Evans is a lecturer in the Department of Psychology from Universitas Kristen UKRIDA Wacana, Indonesia. He earned his doctorate from Universitas Pajajaran, and his research focuses on areas of the psychology of religion, parts of positive psychology, and adolescent development. Bu Anita is also a lecturer in the Faculty of Psychology at Universitas Kristen UKRIDA Wacana. She earned her bachelor's degree and master's degree in Faculty of Psychology, Universitas Gadjah Mada. She focuses her research and community service using a community-based participatory action research approach, and her current research focuses on culture and mental health. Without further ado, let us welcome Pak Evans Gary and Bu Anita Novianti. The screen is yours. Let me remind Pak Evans and Bu Anita,
thank you, Dr.
we'll
Jody.
have 25 minutes to present.
Okay, thank you, everyone. Thank you for having us. My name is Evans Gary, and with my colleague, Ms. Anita Novianti, we are going to talk about the issue of religion and mental health. We are so humbled to be involved and to be able to present what we know so far. So we call our presentation Where We Are and Where We Can Go. In this presentation, we will divide into 2 parts. For the first part, I will be speaking from a religion perspective, and my colleague will talk more from the mental health perspective about the relationship between religion and mental health. I would like to start my talk by sharing a little bit of history. We can trace back the relationship between religion and mental health in history. Excuse me if I quote from the Bible. In the Bible, from the book of 1 Samuel, chapter 21, verse 15, there is a story of a young individual named David, who who was running away from a king named Saul, the king of Israel at the time. And David eventually arrived at a place called Gath and was asked by a servant of King Achis, the king of Gath. The servant was asking who he was and that he had killed tens of thousands of people. David took the questions deeply and quickly became afraid, and so he pretended to be insane. It was told in the story that he acted like a madman, making marks on the doors of the gate and letting saliva down to his beard. Some authors pointed out that this story is an example of the application of psychiatry. So after a little bit of history, now I would like to explain to you about the relationship between religion and mental health in three folds. The first part is troubled relationship. Hood, Hill, and Spilka, the authors of the Psychology of Religion book, explain that religion and mental health had troubled relationship in the past due to their conflicting views on human nature. Why is there a troubled relationship? Of course, because the difference between the philosophy of both religion and mental health, but also mental health as a science mostly views human with a scientific methodology, objective, rational, and reliable evidence, while religion seems to be subjective, emotional. A researcher named Ian Barber developed a framework of the relationship between religion and science. He grouped the relationship into four types, which are conflict, independent, dialogue, and integration. And we can see in Barber's framework that the relationship between religion and mental health varies from conflicts between contemporary science and traditional religious beliefs to integration between the two. After talking about the troubled relationship, I move to the challenging relationship between religion and mental health. What most challenging of the relationship between religion and mental health is the lack of education and knowledge between the two fields. Most professional from both sides, from religion and mental health, may be unaware or less informed of the concepts between religion and mental health. So this is challenging for both parts to be able to educate and to give more information about both religion and mental health. And the third part is a promising side of the relationship between religion and mental health. Most studies show that religion is significantly related to mental health. For example, individuals turn to their faith when they experience adversity, and that leads to a positive outcome. And in our study, we try to develop a scale to measure what we call religious attribution. We name the scale religious attribution scale, and we also give the scale of meaning in life. And we found that religious attribution and meaning in life to be correlated significantly in a sample of disadvantaged adolescents. To add a little bit about the significance of religion to mental health, last night, in the middle of my preparation for this conference, I stopped and watched a movie in Netflix called Live to 100. It's a documentary hosted by a man named Dan Buettner from National Geographic. In the movie, he investigates on how people in parts of the world have a long life. He came to several countries, met with elderly people who live more than 90 years old and even up to 100 years old, and interviewed them. He found several factors contributing to longevity, and from the interviews, he also found that religiosity is also a significant factor for some Japanese, Sardinian, and also American. And there's an interesting interview when Buettner asked an 88-year-old American man, an elderly Adventist, a denomination of Christian, do you generally worry about things or are you generally at peace? The man answered, I would say I am generally at peace. Your emotional health is not good when you worry about things. So despite of the significant correlation, previous findings also showed the relationship between religiosity and mental health have mixed results. For example, in individuals with anxiety, many studies found religious people to have less anxiety, but there are some studies who found religious people to have more anxiety. Next, I would like to talk also about stigma, a little bit about stigma. Stigma has been found to be one of the factors that impacted the attitudes of individuals. From Tanhan and Young study, they reviewed the more Muslim individuals perceive stigma for seeking mental health services, the more likely they improve negative attitudes towards the services. From the other study, Lloyd, Menges, and Bree, solely spiritualization of psychological distress may create self-stigma in individuals within Christian community. After speaking about stigma, now I would like to take you to the challenges ahead. I quoted here from prominent researchers in the field, Harold Koenig. He proposed at least 20 questions that we need to cover on the area of the relationship between religion and mental health, from the causality to the spiritual integration outcomes. So we can see here there are much work to be done to understand more about the relationship between the two. Not only that these questions are important for us, we also propose that we need to be aware of the contextual concepts regarding religion and mental health. We also propose that what concepts that we use in our daily conversations. For example, our study about the meaning of religiosity and spirituality among young adults in Indonesia showed that there were similar meaning regarding both terms. And that study led to the next study about the concepts between among the religious, spiritual, or rohani. And I found that rohani, the term rohani, is more famous. People are more aware about the term rohani rather than religious and spiritual. And furthermore, we also conducted, in our new project, we also conducted a study to explore the meaning of rohani through the photo elicitation method. And although our main finding is that, in general, individuals understand rohani as personal experience with God, we also found that there is a theme of well-being issues when describing rohani. So our findings are initial findings that need to be studied further in order to understand better the reality of religion and its relationship to mental health. So to close the first part, I would like to say that there is still much work to be done to understand more about the relationship between religion and mental health. And from what we have so far, I think it is safe to say that we need both religion and mental health for mankind to live well and to be optimal. Like the famous saying, it takes two to tango. So, Miss Anita, are you ready to tango?
Okay, thank you, Pak Evans. I will share my slide. Can you hear my voice clearly? Okay, everyone, disclaimer first. I'm not the expert on the religion and mental health topics, but Pak Evans did. So here I want to share my preliminary research with my students in several cultural backgrounds in Indonesia. So we can see where the position of religion in mental health discussion. So first, in 10 minutes, I will deliver this presentation quick. For the context, in low and middle income countries, the gap between prevalence of mental disorder and the professional treatment is long-standing problems. There are several reasons, from low mental health literacy, stigma, like number of mental health workers and services, as well as the high cost of professional treatments. It also happened in Indonesia, and then we also have the problems with the distribution of mental health services, which mostly concentrated in Java Island. So complementary and alternative medicine is the best option for them. So the form of cultural and alternative medicine in mental health, such as herbal medicine, traditional or culturally based treatment, or faith-based healing. The reason is they are easy to access, flexible in payments, similarity of the values and belief between healer and patients. So there is also the article state that clinical psychologists in Indonesia aware that their patients access charm while access their treatment, professional treatment. And interestingly, the knowledge of Indonesian clinical psychologists about charm is low, but their attitude is positive. And most of them use it personally, but only half of them had ever used it in clinical practice. So from this point of view, we knew that biomedical treatment and charm usually accessed by patients interchangeably or parallel at the same time, depend on their reason from the internal factors, maybe depend on their evaluation about the analysis of the causes and social influences, or in most cases, the informal help usually accessed because the external factors, such as the absence of treatment and difficulty in accessing the treatment. So my research findings also found out that in the context of slum area in Jakarta, which mostly participants were mothers with lower education, formal help-seeking intention was strongly predicted by community attitude towards mental disorder rather than individual mental health literacy. It means when the neighborhood and the family have strong stigma toward mental disorder, they tend to access the informal help, such as supernatural healer or dukun or religious leader. And my research with my students in several cultural background groups in Indonesia, we try to explore the lay people understanding with major depression disorder and schizophrenia vignettes that validated by expert judgment and also validated by the representative of participants, because some of vignettes were translated into their local language. And the demographic characteristic of participants consists of people from Ambon, Marin in Merauke, Kupang, and Batak. And if you can see on the right side on your screen, she is one of my students that collected data in Merauke, Papua at the time. So what we found out is, first, how they recognize or label the vignettes. Most participants did not recognize the vignettes in psychiatric label. Instead, they label the vignettes using common terms, such as abnormal, stress, madness, or in a local term. So why is it important to us to understand the label? Because the label itself, Mark Nichter introduced the term about idiom of distress. Idiom of distress maybe could represent the psychopathology or medical diagnosis, but also could pointing out the social, political, economic sources of distress. So it is important to identifying idiom of distress to lead us to understand the psychological and social suffering at certain community. And the second is about the belief about the cause and the pathway to seek help. So most participants tend to believe that mental disorder were caused by personal factor, social factor, religion, culture. So they prefer to access informal help rather than formal help. Informal help including close friend or family, religious leader, traditional hero, or community leader. So at least there is a two global mental health agendas that could, I think, maybe more that could be involved the religious leaders in the mental health interventions. First, the task shifting program, and the second is the contextual medicine. The task shifting programs means involving non-specialist health workers to provide mental health services. So there are several task shifting programs were implemented in several countries in LAMIX, in Ghana, in India, also in Indonesia. So there is opportunities actually to this kind of program, but also there are challenges such as over-medicalization, over-medication prescription by non-professional, also the sustainability issue. So I asked a question, is it possible to provide training to community gatekeepers, such as religious leader, community leader, or traditional healer, to assist people in recognizing symptoms of mental disorder and doing referral to a specialist group? And the contextual medicine actually, the World Health Organization acknowledged the need to recognize the diversity in treatments, and there is opportunities with this because there is an article which for me is very interesting. If you can see the top 3 causes of mental disorder that they believe are social, psychological, and biomedical. Very small number of people believe supernatural factor was the cause of mental disorder. However, the 3 top treatments that were accessed by them, number 1 is spiritual therapy and medical intervention, and following by psychosocial intervention. But now on another side, those are challenges, such as in Ghana context. They interview the Christian healers, herbalists, and the shrine priests, and also the Muslim healers. The Christian healers and herbalists are willing to collaborate into biomedical system, but Muslim healers and priests did not want to collaborate into biomedical system. The argumentation from the researcher is it's because the distribution of power. In Ghana context, Christian healers and herbalists are more well known by public, as well as more closer to the formal economy in compared to Muslim healers and shrine priests. So here's my last slide, call to action. Things need to be considered in collaboration between biomedicine system and traditional or cultural alternative medicine practitioners. First, I think collaboration amongst health system must be considered. Of course, the patient welfare will be the priority, but also we have to consider the perceived advantage to different healers. Because at least in a Ghana context, the healers who considered themselves to be most powerful were most willing to work with other health systems. And the second is task sharing. I think we could divide our roles in terms of mental health intervention, and every layer of social groups could take a role. And the third is integrated and holistic healthcare system. Are we going there? And this question will be closing with my presentation. Thank you.
Thank you, Bu Anita and Pak Evans, for your presentation. If any of you have any questions, please save your question till our plenary session, or you can use the chat box if you don't want to forget or if you don't want to write down somewhere. So now we are ending the first half of our talk show series, and I would like to invite everyone to take a picture together so we can remember this moment and this event. So I would like those who are willing to share, open their video so we could take a picture. Pak Adit, if you are able to assist me in taking this picture. Okay, so I would like to invite everyone to take a break for 15 minutes, and we will come back to this Zoom meeting at 18:45, and we will continue with our webinar series with two keynote speakers, very anticipated keynote speakers, Dr. Munishea and Dr. Eva. So I will see you in 15 minutes, and hopefully we can spend this time continue for break, so you can go to the toilet, you can drink, or so on. So see you in 15. Good evening and welcome back to our international talk show series. And we are now expecting two more keynote speakers, and I hope all of you have had your refreshments and have your break, so we can begin with our second part of this online conference. So I would like to introduce our next keynote, Dr. Munishea, with the topic Addressing Barriers and Providing Accessible Mental Health Support to Students in Higher Education. Dr. Munishea is a professor of clinical psychology at Seattle Pacific University. Her research focuses on the intersection of culture and mental health, specifically on how culture influences individuals' experiences and expressions of mental health concerns, and on translating this knowledge into the design and implementation of culturally responsive psychological services and intervention. She received her PhD in counseling psychology from Columbia University. It's very good to meet you, Dr. Munishea. Hello. I will now begin with presenting her presentation. And again, if any of you any of the participants want to ask a question, please feel free to use the chat in the Zoom meeting.
Good afternoon, everyone. First, I would like to extend my heartfelt gratitude to UKRIDA for extending the invitation to me, allowing me the privilege to participate in this Global Mental Health International Talk Series. It's with great honor that I share with you today my thoughts and insights. Recently, my children, seen in the pictures here, and I went on a short trail walk near my university in Seattle. The park is an oasis in an urban city and has a 3-mile or 5 kilometers looped trail. We parked our car, walked down the shaded trail, which took us all the way to the lighthouse on the beach. We ate our sandwiches on the beach, listening to the waves crashing against the shore. It was a beautiful day. Our return journey followed the same loop trail until an unforeseen challenge arose. I couldn't remember where I had parked our car. So there were 4 parking lots. I vaguely remember parking near a visitor center at an entrance, but that detail failed to provide much clarity. It was intensified by the fact that all 4 parking lots were located near park entrances. So I try to recall if there were any other landmarks to help me eliminate options. While my kids remained mostly calm, they began to grow uneasy and asked me, "Mom, why don't you ask someone?" After walking for a while. Why didn't I ask for help? Perhaps I felt embarrassed for being so forgetful and absent-minded. Perhaps I wanted to be self-reliant and find a solution myself. There was also an element of uncertainty. Would anyone we approached be more equipped to find out where I had parked my car than I was? Social psychologist Isaac Agen proposed the theory of planned behavior to explain an individual's propensity or likelihood to engage in the behavior or not. According to the theory, individuals' actual behaviors and intentions to act are shaped by their attitudes towards the action and ensuing consequences. Someone might have a positive, negative, or neutral attitudes about a given behavior. As an individual's attitude becomes more positive, their intentions to perform that particular behavior will also increase. Second, behavioral intention is also influenced by subjective norms, which refer to individuals' perceived social expectations to engage or not engage in an action. As an individual's subjective norms increase, their intentions to perform a behavior will also increase. Third, perceived behavioral control refers to self-efficacy, encompasses the extent to which individuals believe they have control over performing that behavior. Higher the perceived control, the more likely they will engage in the behavior. So the planned behavior theory has been used to understand health-related behaviors, including psychological help seeking. For example, a favorable attitude and evaluation of an action, such as seeking counseling, can increase my perspectives and also improve my relationship with others, is likely to increase the person's intention and actual help-seeking behavior. Also, if someone holds a positive normative belief and think others would approve their decision, such as people from my community will support me and will not perceive me as not wise, then they are also more likely to seek help. And finally, if someone thinks or feels that they have a sense of control over the situation, such as I know when and where to get help, then the person is also more likely to act. So what factors influence an individual's attitude, subjective norms, and perceived control? Particularly, what challenges or barriers might students in higher education encounter when they decide to seek mental health support? Before I delve into the specifics, let me offer you a roadmap for today's presentation. To begin, I will first describe the barriers that often hinder college students from seeking the support they need, and the obstacles that hinder the delivery of mental health services on campus. Specifically, these challenges are influenced by complex social and cultural factors. Second, I will spotlight tangible examples of both effective and emerging practices and interventions that educational institutions can use to address the prevalent mental health challenges faced by college students. These strategies encompass a spectrum of approaches, each tailored to meet the diverse needs of students while promoting accessible and comprehensive support. I would also like to emphasize the profound significance of advocating for policy changes at the institutional level. Recognizing the transformative potential of policy shifts, I will underscore the importance of driving change that will enhance the quality and accessibility of mental health services for students in higher education. In my concluding segment, I want to issue a call to action. Institutions need to take innovative steps to foster a more resilient and mentally healthy student community. By focusing on policy advocacy, we can create a lasting impact that transcends individual practices, echoing positive effects through the entire institution. So this slide, first of all, why should we care about the topic of mental health among college students? Multiple studies have shown the alarming trend of rising mental health issues among this demographic group. This slide shows you some statistics from a comprehensive Healthy Minds study, which was a collaborative effort with the American College Health Association. The results indicated that nearly 3/4 of students reported experiencing moderate to severe psychological distress. This finding resonates with the realities of the academic environment and the broader challenges students face in their personal and educational lives. To shed light on the scale of this issue, let's look at the data collected from this study more closely. The study collected data from 32 campuses during the fall semester of 2019, with additional data gathered from 7 campuses during the period of March to May of 2020. The green bar shows statistics from the semester of 2019, while the blue bars show figures from the spring of 2020. As you can see, this data shows the persistent prevalence of mental health symptoms, both before and during or shortly after the pandemic. The trend remains consistently high among college student population regardless of the onset of the pandemic. A nuanced analysis of the data reveals a striking increase in the prevalence of depression during the spring of 2020. Simultaneously, substance use reported by students decreased during this period. Can you guess why that might be the case? Maybe it's because of the shelter-in-place policy and that students were not socializing with their peers as much. Furthermore, the study looked at the intersection of mental health and academic performance. A higher proportion of students during March to May 2020 reported that their mental health had a detrimental impact on their academic achievements. Now, these statistics may seem a little bit pessimistic, but there are positive signs. Post-pandemic, students reported higher levels of resilience, showcasing their capacity to adapt and persevere in the face of challenges. Worldwide, we see similar findings. The World Health Organization's effort, specifically the World Mental Health Survey's International College Student Project, highlights the universal nature of mental health concern. The project surveyed 19 colleges and universities across 8 predominantly high-income countries, including Australia, Belgium, Germany, Mexico, Northern Ireland, South Africa, Spain, and the United States. The findings show that a substantial portion of university students, up to 35%, met the criteria for lifetime mental health disorders. Furthermore, within the past 12 months, 31% of the students experienced mental health challenges. Major depressive disorder was the most common of the disorders examined across all countries. Following closely is generalized anxiety disorder, both of which underscore the gravity of the mental health landscape among college students. Within the Indonesian context, one study reported that between 25% and 50% of Indonesian university students experience various mental health concerns, such as stress, depression, and anxiety. These findings altogether show that both on a global and regional scale, there's an urgency to address mental health challenges among college students. Despite the high prevalence rates, the majority of students do not seek professional psychological services, delay seeking help, or rely on informal support. Untreated mental health problems have been associated with severe negative academic, social, and psychological consequences. So we are coming back to this question: why do they not seek help? It is a complex phenomenon that can be attributed to a combination of factors. My colleagues Paul Kim and Don Lee at Seattle Pacific University proposed to use an interpersonal framework to understand both within and between person aspects of help-seeking barriers among college students. Intrapersonal barriers may include cognitive barriers, such as one's negative perceived value of professional help. Some students grew up in a culture where they feel more comfortable relying on their families or friends for support rather than seeking professional help, or they might just think that counselors or psychologists cannot help them figure out their problems. Intrapersonal barriers may also include emotional barriers, such as lack of emotional openness or fear of disclosing one's emotions to other people. Interpersonal factors, on the other hand, refer to the relational aspect. social stigma, which is the negative perception about professional counseling held by others, especially those who are in close contact with the person, may mean that I'm afraid that if I do certain things, people in my community may judge me. For certain cultural groups, mental health issues can be seen as highly stigmatizing, and seeking professional help can also bring shame to one's family or community. Kim and Lee propose that these intrapersonal and interpersonal factors together can increase or decrease an individual's intention to seek professional psychological help. While this model is helpful, its focus is on the individual and did not address external or structural barriers. Reflecting on my experience of getting lost in the park, it's possible that my hesitation to seek help wasn't rooted in my sense of embarrassment, a desire for self-reliance, or a fear of getting assistance. Instead, it could be attributed to some external factors that are beyond my control. For instance, not having reliable cell phone reception in the park made me unable to call or text anyone for help. Or perhaps there were no clear path markers or maps to direct me back to the parking lot. So taking into account the interplay of intrapersonal, interpersonal, and contextual factors, my research collaborators and I have proposed an innovative multidimensional framework for understanding the barriers college students face in seeking psychological help. In addition to the previously mentioned cognitive, emotional, and social barriers, we propose that it's equally important to acknowledge structural or logistical barriers as well as cultural barriers. Structural barriers encompass challenges such as students lacking information about available services on campus or encountering hurdles like extended wait times, financial constraints, or overwhelming responsibility that stop them from getting help. Furthermore, cultural barriers refer to scenarios where students struggle to find providers who comprehend their cultural experiences, worldviews, and values. Instances of bias or stereotypical beliefs held by providers, along with unintentional microaggressions, can also contribute to cultural mistrust and hinder students' help seeking. This holistic framework aims to capture the full spectrum of challenges that students confront when seeking mental health support, recognizing that a comprehensive understanding necessitates addressing the intricacy of individual, interpersonal, and external or structural factors. Beyond the barriers students face on an individual level, institutions also grapple with obstacles and complexities in delivering and maintaining sustainable mental health support. These challenges encompass a range of issues. First, resource constraints. Limited funding and budgetary limitations often result in an increased workload for counselors, leading to extended wait times for services. Moreover, resources for professional development training for counselors, faculty, and staff, as well as the establishment of wellness programs, are also hindered by these budgetary constraints. Second, cultural awareness limitations. Institutions may encounter difficulties in offering culturally competent and culturally safe mental health services due to a limited understanding of mental health. The absence of nuanced awareness can also hamper efforts to cater to the diverse needs of students from different backgrounds. Third, lack of holistic strategies. There might be a lack of comprehensive long-term strategies aimed at promoting sustainable well-being across the board. This includes not only the well-being of students, but also extends to the mental wellness of educators, including faculty, staff, and administrators. Fourth, insufficient program evaluation. A lack of consistent and thorough program evaluation limits the identification of effective prevention or intervention approaches. The absence of ongoing evaluation makes it challenging for institutions to discern which programs yield the most favorable outcomes and thereby which programs to retain and continue. So how do we provide culturally inclusive and accessible mental health support in higher education? Having examined the array of barriers that college students may encounter while seeking or receiving mental health services, we will continue to reflect on this question. I invite you to take away one fundamental principle and one pivotal question. The one fundamental principle is person-environment fit. This psychological concept focuses on the dynamic interaction between individuals and their surroundings. Central to this theory is the notion that when there is alignment between individuals' attributes, values, and beliefs, and the characteristic of their environment, a state of well-being, satisfaction, and optimal performance can be achieved. In other words, a one-size-fits-all approach will not suffice, just as gardening or farming necessitates specific conditions for different plants and crops. So too does each student require tailored care based on their unique needs. So now the pivotal question is, how can we establish a multifaceted, multi-tier system of support that cultivates a resilient campus community? I will present you with examples of ongoing efforts and innovations being implemented across college campuses in the following slides. So first of all, efforts to overcome the access barrier gap have led certain universities to adopt a proactive strategy. Using screening tools, rapid assessment, and same-day walk-in appointments, these universities aim to significantly diminish wait times and enhance accessibility. Some institutions have also taken the initiative to offer free psychological tests, including the Minnesota Multiphasic Personality Inventory, MMPI, to incoming students. The students who are identified as potentially facing mental health challenges receive personalized invitations to interpretation sessions for test results. Should the need arise, these students are directed to counseling services. So the strategy really places a strong emphasis on early intervention as a preventive measure. In terms of addressing social and cognitive barriers, for students harboring a negative attitude towards seeking help or doubting the efficacy of counseling, universities are implementing diverse outreach programs. These initiatives encompass a wide range of activities geared towards promoting mental health awareness, fostering understanding of available support options, and reducing stigma through education and engagement. Here are some specific examples of community engagement and outreach by the University of Michigan. You can see that they hosted workshop presentations, large-scale tabling events, campus-wide partnership program, and also lunch series. These outreach events extend an invitation for staff and faculty to actively participate. So they are not only for students or counselors. The strategy is to reinforce a holistic approach and strengthen the community engagement. Another creative strategy for promoting mental health awareness and interest is the implementation of essay contests. For example, the International Honor Society of Psychology, PsyCI, hosts social media essay contests, asking people what mental health support means to them. Instead of defining what mental health support should be for our student, this strategy invites students to share with us what type of support they would like to have. The social media posts can also serve as a catalyst for open discussions, encouraging dialogue around mental health in a positive and engaging manner. I have included the links to the University of Michigan outreach program, as well as the link to the PsyCI website in the resources page. Just a moment here. And then going back to cultural barriers, we know that cultural barriers often arise from factors such as the absence of culturally competent counselors, perceived language or cultural differences, or a lack of familiarity with traditional counseling approaches. In response, several strategies can effectively address these cultural barriers. An important starting point is the language we use when discussing mental health and related support. Talking about mental health, well-being, and wellness instead of mental illness or disorders can promote a more positive and inclusive dialogue. Similarly, using terms such as coaches and advisors instead of counselors or therapists might be more relatable to students who are less familiar with psychological counseling services. Additionally, we must consider the delivery methods and settings for services to promote access and reduce stigma. For instance, my research team and I devised an intervention program for college-going mothers. Rather than hosting group sessions within the counseling center, we met weekly in a classroom. This approach not only mitigates logistical challenge, but also diminishes stigma. For the participating mothers, the intervention program resembles an extracurricular club meeting, further facilitated by the presence of a student mother co-leader. Moreover, we can enhance awareness of the intrinsic link between academic and psychological well-being. A recent example involves one of my doctoral advisees who introduced a curriculum-embedded gratitude intervention to enhance college students' mental health. This brief intervention, delivered online and asynchronously through a psychology course taught by another faculty member, yielded positive results. Students in the gratitude intervention group experienced significant reduction in stress and anxiety compared to peers in the control group. This underscores the effect of integrating positive psychology interventions within courses, offering an accessible, low-cost, non-stigmatizing avenue to provide mental health support. While many higher education institutions provide in-house student psychological services, expecting counselors to single-handedly resolve all student mental health issues is unrealistic. To establish a comprehensive web of care or multi-tier support system, researchers advocate for a holistic approach that involves staff, faculty, and administrators in shared responsibility. Faculty, due to their substantial interaction with students within classrooms, can play a pivotal role in identifying mental health concerns and guiding students towards appropriate services. Here are some actionable suggestions. First, higher education institutions can require and provide professional development training for faculty to enhance their understanding of student mental health well-being and effective referral processes. One example is the Mental Health First Aid Training Program, which holds promise for implementation at the university level. Second, institutions can incentivize staff and faculty engagement in mental health outreach by creating funding opportunities for innovative intervention or prevention initiatives, such as department-level peer mentoring program or university-wide workshop focused on mental health. The campus community can be actively involved. Additionally, annual evaluations, including professional development plans and feedback, can incorporate an assessment or reflection of faculty engagement in mental health-related learning. Third, a structure should be devised to establish a connection between academic success and well-being whenever possible. An illustrative case is Seattle Pacific University's Early Alert System. This mechanism allows our faculty to communicate any academic concerns a student might face, triggering appropriate campus parties to intervene and provide recommended services. Fourth, institutions should explore collaborations with external organizations and sponsors to promote student mental health support. For instance, college and university mental health staff can establish connections with local providers, connecting students to practices with existing affiliations. This approach enables access to low-cost or no-cost options, extended service hours, multilingual support, or specialized care aligning with specific identities or health concerns our college students face. Well-being is a holistic concept that encompasses physical and mental health, a sense of safety, belonging, and connection, and practical coping mechanism for stressors alongside accessible mental health support. Recognizing this, it is imperative to acknowledge that counseling or student services alone cannot bear the responsibility of student mental health support. Building a resilient campus community requires that higher education institutions to honestly examine and address the entire campus culture and the environment towards mental health. To illustrate, many institutions grapple with fragmented or outdated mental health policies, misaligned procedures, and practices that don't actually achieve student wellness objectives. Addressing this requires identifying gaps in knowledge, correcting misalignments, and conducting consistent evaluations of existing psychological services and programs to refine practices. Second, institutions should prioritize mental health and financial constraints. Mental health problems, if left unattended, not only cause personal distress and have implications for the student's academic and career development, but they can also have long-term impact on campus community and financial implications for the university when students cannot finish and need to drop out. Higher education institutions possess not just the capability to educate and inspire the minds of our students, but also bear the responsibility to nurture their well-being and guide them in realizing their utmost potential. Third, given the amount of time students spend in classroom and residential halls, institutions must dedicate resources to empower faculty, staff, and students to care for themselves and one another. A one-size-fits-all approach is inadequate. For example, in recent years, online learning gains prominence. It's important for institutions to explore avenues for telehealth support, extending inclusive and equitable services to online students as well. I invite each of you to envision a resilient campus community that places mental health at the forefront of its priorities. Our collective efforts will entail crafting an environment that not only acknowledges the challenges, but also take affirmative actions to promote the well-being of every student. By fostering a culture of compassion, understanding, and proactive engagement, we can create a space where mental health is normalized, destigmatized, and readily accessible. Together, we can cultivate an educational environment where each student can flourish and thrive. Here are my references and also resources to the two websites that I mentioned in my talk. Thank you very much. And you can find my contact information here.
Okay, thank you, Dr. Muniche, for your presentation. Apologies for the technical error. But I would pretty much like to explore your presentation with you in the plenary session if that's possible. Okay. I would like to remind all participants if you have any questions, you can put them in the chat room and also, or keep them until the plenary session. Okay. Now, I would like to introduce our last keynote speaker for today. Let me share Dr. Eva Suartana from McGill University.
Selamat malam, Pak Jody.
Halo, Dr. Eva.
Citra.
Oke, senang sekali dokter bisa join hari ini, Dok.
Jadi ini Dr. Jody yang play ya?
Siap. Jadi Dr. Eva Suartana, now as a health technology planning, programming, and research officer in Health Technology Assessment Unit of the McGill University Health Center, an adjunct professor in the Department of Obstetrics and Gynecology at McGill University, and also a research associate from Research Institute McGill University Health Center. She finished her PhD at Utrecht University, Netherlands, and her postdoc at the CDC, USA. I would like to give a warm welcome to Dr. Eva. You may present your materials.
Dr. Jody, is it okay if I share my screen?
Okay, you can.
Okay. I have some animation. Thank you.
Okay, sure.
Thank you so much. Okay. Can you see the screen now?
Yes, we can.
Okay, thank you. Yes, so thank you again for the opportunity to talk today. So first of all, selamat malam untuk semuanya yang hadir yang sudah malam di Jakarta. And I saw like the previous speaker of Indonesia is in Seattle, so good morning for you. Yes, so, and first of all, also congratulations to UKRIDA for celebrating the Dies Natalis 56th anniversary this year. So thank you for having me. In the next 20 minutes, I'll try to talk about pregnancy, endometriosis, and mental health based on our work at McGill University. Okay, I just want to show that this is our department chair, Professor Togas Tulandi. He's also an alumni of the Faculty of Medicine, University of Indonesia from the 70s, early 70s. And he is very enthusiastic in the research of endometriosis because it affected the life of so many women patients that he's seen in the clinic. And that's the reason why he keep on working and doing research in endometriosis. So what is endometriosis? For those who are not familiar with the terminology, it is a condition where so this is like our uteri, and the endometrium is supposed to be like the cell lining that covers the inner side of our uterus. So supposed to be within this organ, but when it places somewhere else, like it could be outside the uterus, it could be in the fallopian tube, it could be in the ovary or other organ, it could be like go down to the cervix, the vagina, and surrounding organ, and we call them endometriosis. And the reason it cause some problem because just like it follows the rhythm of the menstrual period, so that's why patient could experience some pain, especially excessive menstrual cramps. Some of them could have infertility because like if they ended up in the fallopian tube or in the ovary. It could cause vaginal bleeding between periods. Yeah, if it's, for example, located within the vagina, it could cause painful urination and painful bowel movement during menstrual periods. It could also cause, on the other hand, diarrhea, constipation, or nausea, lower back pain, pain during intercourse, general fatigue, and abnormal or heavy menstrual flow. And this is a busy graphic, but I'd like to show that there are 176 million women worldwide, so almost like almost 200 million women worldwide are affected by endometriosis. And why it is very important because 1 in 10 women in the reproductive age in the UK, so this is statistic mostly from the UK, suffer from endometriosis. It costs the country more than like $8 billion annually for the treatment and the loss of work, healthcare costs per year. And in spite of that, the treatment itself, there is no current like really definite cure for endometriosis currently. only 1/3 of women feel that their current pain treatment is effective. So that's why the pain is, some patient might have like mild symptoms. Some people might have like severe that affect their ability to be active during the period, and even like so they can miss work because of the pain. Yeah, so and related to our webinar today, a lot of them, yeah, like almost 1/3 of the endometriosis patient, they also suffer from depression mostly because of the chronic pain. So this we try to look at the association between endometriosis and the risk of preeclampsia, because there are some postulates that endometriosis is not only, although we saw that in the previous slide that it affected several organs, but there's also a postulate that actually endometriosis is a systemic condition. So, and that's how it could affect, for example, pregnancy and cause preeclampsia. So we did a systematic review meta-analysis looking at specifically the association between endometriosis and preeclampsia in spontaneous pregnancy. Why we selected some spontaneous pregnancy, yeah, because we know like some women with endometriosis could have infertility problems, so they would have the pregnancy through the IVF, but IVF itself could be associated with the hypertension during pregnancy. So that's why we want to exclude that confounder from our analysis, and that's why we limited our study to subjects who conceive spontaneously. Yeah, this study was featured by Endometriosis Foundation in America. So we found actually we started with almost like 600 studies, but only 3 met our criteria because we have, like, as I mentioned, we only look at spontaneous conception. And of those like 3 studies, yeah, the number are not too big. Yeah, we have a total of 65,000 women in the study who had no, yeah, in total we have like 65,000 women, and 1,463 of them had endometriosis. So we look at the risk of preeclampsia among those with and without endometriosis, and our forest plot showing that having endometriosis is actually increase the risk of preeclampsia by almost 50%. Yeah, we also look at the risk of C-section among those with and without endometriosis. We look at here, although the odds ratio is high, a bit high, like showing 40% increase in the probability of having C-section. However, the association is not significant, and you can see like we only have 2 studies in meta-analysis, and we have a very high heterogeneity. And so the finding for C-section are not too convincing. Similarly, we look at postpartum hemorrhage. Also, we also look an increase of by 16% in the risk ratio between those with and without endometriosis. But again, the association is not significant. We have very wide confidence interval and also pretty high heterogeneity. So the second study that we look regarding endometriosis is we try to look at the implication on quality of life. And the study I demonstrate here is originated from Indonesia. So we collaborated with our colleague from Rumah Sakit Cipta Mangunkusumo in Jakarta. So they look at subject, women with endometriosis, and if they have association with psychiatric disorder and quality of life deterioration. And we have 160 subjects in the study, and we look at their FAS, visual analog scale for pain, where 0 is pain-free and 10 is very painful. So we look at, we dichotomize the FAS, the analog scale, into like lower than 7 or 7 and to 10, like which is severe pain. And we try to evaluate what factors associated with severe pain in women with endometriosis. Yeah, and we saw that surgical history definitely will increase the pain, the severity of the pain. But also, like we saw that psychotic disorder increase the pain, the severe pain, by 70%. And when I say psychotic disorder, we look at different mental health problems, but the majority of the patient reported either depression or anxiety. And we also look at the quality of life. So we are using the endometriosis health profile, EHP 30 questionnaire. So the score range from 10, best quality of life, to 100, worst quality of life. The same thing, we look at the characteristics, and we try to evaluate the association between quality of life and psychiatric disorder and chronic pain. So we can see here, having chronic pain significantly increase the score, which means it has a lower quality of life. The same thing, having psychiatric disorder, depression and or anxiety, will also increase the score, which is like having lower quality of life. So what we can conclude it from just these two studies here, there are a lot of studies like showing similar outcomes. But one, like I try to show that even from Indonesian cases, that women with endometriosis, unfortunately, they have like a lower quality of life, and hence, and therefore comprehensive management of endometriosis is crucial to improve patient quality of life. And for women who are going to have pregnancy, like if you like meet patient with endometriosis who are going to have or planning to have a pregnancy, we would like to recommend to have a very thorough evaluation, because they are at risk also to have preeclampsia, and also actually we also look at another association with psychiatric disorder. It's not shown here, but we notice, we observe that people who have endometriosis, even without chronic pain, they also have higher probability of having anxiety and depression. So screening is very crucial in order to improve the quality of life, to have a better treatment, to have a better follow-up and thorough follow-up, not only among the pregnant women, but for endometriosis patients in general. Okay, so the second part of my presentation is about pregnancy hypertension. Yeah, so what is the connection between pregnancy, mental health disorder, and also the neonatal outcome? So this is the first study that we did. We use a US database, population-based study, HCAP, National Inpatient Survey. So it's a very large database. So we did evaluation in 9 million pregnancies. And what astonishing that we look at the trend of anxiety and different type of hypertensive disorder in pregnancy. So you look at this, the blue line is the prevalence of anxiety and gestational hypertension. So we look the trend from 2004 until 2014, and yeah, it keeps on increasing. Like we calculate the prevalence in 2014 is almost 6 times higher than what was found in 2004. The same thing with anxiety and preeclampsia. With eclampsia, we saw like rather like flat line because there's too many, like too small number to actually to see a strong trend. So this is really suggesting that we really need to look at anxiety, screening for anxiety and depression for women in the first trimester of pregnancy is very crucial because they increase all together. Yeah, and the finding is featured by Psychiatric News. It is the official bulletin and newsletter from the Association of American Psychiatrists. So we recommended very strong early screening for mental health problems among women, pregnant women in the first trimester, because the earlier we could identify them, the earlier we can treat, and yeah, by prevention, hopefully we can prevent adverse neonatal outcome. So yeah, given that thought, after we published the first paper, we tried to look at what's association between like which one like comes first, like which one is really affecting. Like, is it like having mental illness first, like having anxiety first, and then later on it will trigger hypertensive disorder, and then have a negative neonatal outcome, or having like hypertensive disorder during pregnancy and it trigger anxiety during the pregnancy. So which one really like comes first? So to look at that association, we use the same database again in 9 million pregnancy. We use more sophisticated statistical analysis. So we look at the moderation between hypertensive disorder during pregnancy and preterm birth or small gestational age among the neonatal, the babies that were born from this patient. And we also look at the mediation model between hypertensive disorder, anxiety, and the neonatal outcome. So this is the result that we found, like what we gain from the analysis. We first we look at anxiety and HDP. So people with anxiety, like women with anxiety, will have 20% higher risk of having hypertensive disorder during pregnancy, and subsequently people who have high hypertensive disorder will have also another 20% higher risk of having negative neonatal outcome, like preterm birth. Yeah, so while if you look at between anxiety and the preterm birth alone, the odds ratio is slightly higher than 1. So we showed like a very positive, significant mediation effect between HDP, HDP as the mediator between anxiety and preterm birth. And we look at depression as moderator. So we look at here the predicted probability of having preterm birth. The blue bar here is for women with no depression, and orange is those with depression. And we look at the combined effect of depression and HDP on the neonatal outcome, and we observe significant moderation effect. Yeah, it's negative here. It has a negative moderation effect, which means when you have HDP and depression all together, the chance of having PTB is lower than having HDP alone. And it could be explained by the effect of depression medication, which might lower the blood pressure. So that's why we have lower probability of the preterm birth among the babies. And we look at another outcome, small for gestational age. Yeah, the same pattern we can see between anxiety, high hypertensive disorder, and a small gestational age. And HDP as a mediator has a positive effect and significant. Yeah. However, when we look at the depression as moderator, we didn't observe significant combined effect between depression and HDP on a small gestational age. So what we could conclude from these two studies that women with anxiety had a greater risk of having hypertensive disorder during pregnancy. And in return, the hypertensive disorder during pregnancy will mediate association between anxiety and adverse neonatal outcome. Yeah, depression increased the chance of having preterm birth, but not for small gestational age. And therefore, we encourage screening among pregnant women for anxiety and depression, and we can actually use very simple tool. Yeah, Dr. Chitra, Dr. Jody might be more knowledgeable than me in terms of the tools that should be used in Indonesia, but we can propose to use, for example, GAD-7 in the first trimester as early as possible to avoid downstream neonatal complication. And it is very important also to destigmatize mental illness among pregnant women, because especially maybe in Indonesia, people are still shy to say that they have some mental problem. So it's become undiagnosed, yeah. And when you don't diagnose, we cannot treat. So that's why early screening and also destigmatization of mental health problem in the population is very important. This is just to show the tool, the GAD-7. As you can see here, you only have 7 questions. We ask them about the well-being within the past 2 weeks. And then from the score, we can stratify if they have minimal, mild, moderate, to severe anxiety. Okay, thank you so much for the opportunity, and I'm happy to answer some questions. Thank you.
Okay, thank you, Dr. Eva, for your presentation. Okay, now we will begin immediately our plenary session for this webinar series. I invite all keynote speakers to join me in this plenary session, and I will give a chance for the participants to ask questions to any presenter that you like, or maybe more than one. You may use the chat, or you may use the reaction and raise hand option if you want to speak directly and open your mic. Okay. So let's see, do we have any participants? Okay, Dr. Chitra.
Okay, can you hear me?
Yes.
First of all, I would like to thank all the speakers, especially those who have had to wake up very early in the morning to be able to be here. So thank you. It's a good testament also for the Indonesian diaspora, where enhancing academia and knowledge development all over the world. I would like to ask all of the speakers to, we are trying here to bring together, I suppose, all the different expertise, and everybody has different specializations. And I suppose we would like to tie everything together, yeah. And from what you have presented and heard from the others, perhaps, are there things that you feel we can connect with to move forward in terms of research collaborations, in terms of actions that can be done, particularly perhaps in the context of the university, but also beyond. A lot of you mentioned, like, for example, Dr. Dian mentioned in the community as well, in the health system, for example. So I would like to hear a little bit from the speakers in terms of our interdisciplinary connections. Thank you.
Okay, so would like to give their opinions first? Maybe Prof. Johanna, do you have any?
Well, transdisciplinary approach is possible when firstly we shall have multidisciplinary approach first, and then when the group will be advanced, then the interdisciplinary approach can become the focus of the research question together. And then the transdisciplinary approach will become likely happen after the group has worked together. That's from my experience working with our colleagues from the Faculty of Medicine and also from other countries within INRUD, International Network for Rational Use of Drugs. So I guess if we'd like to collaborate, then we shall have Dr. Chitra, for example, to tie us together to do the collaboration. Thank you.
Okay, thank you, Prof. Johanna. Any other input from Dr. Eva? Oh, Dr. Dian. Okay, Dr. Dian.
Thank you. Yes, I think hopefully one of the outcome of this, such events is further collaboration. And I think in the chat, at least for me personally, I think I'm connected to one of the faculty staff at the UKRIDA, Yossi, and hopefully we could, discuss for the collaboration. And I think in terms of the topic, as Prof. Prawita mentioning, for me personally, it's because public health and global health is broad. So you can think of all the aspect of NCDs and communicable disease, mental health and health systems, inequality. You can look at from the economic perspective. You can look at from in political economy, or basically all the social science, all the natural science, all the science. In fact, our collaboration with Ibu Bu Eva's team in McGill is also part of the multidisciplinary collaboration. And with my experience working at Harvard and Imperial and now at City, I'm used to working with multidisciplinary people from nutrition, food science, and people from even computer science or math, engineering and all that. So potentially, I think because UKRIDA is also has a big faculty in engineering and also medical faculty of medical science and health science. So hopefully there will be further collaboration afterwards.
Maybe I just would like to follow up on the Dr. Dian Kusuma. So both of us are from the International Ikatan Ilmuwan Indonesia Internasional. Kebetulan, we both of them from the health, medicine, and biotechnology cluster. So we have in total about like more than 300 diaspora inside in Indonesia and outside and abroad who are registered in the cluster. So we have a lot of opportunity if you want to like collaborate in terms of research like this, teaching activities. We just to share the experience with University of Indonesia. We have MOU between McGill and UI, and also like our diaspora, our member in different university, they can help like building up collaborative either through the MOU or a person-to-person relationship, and not limited to only webinar, but we are happy to collaborate in terms of research, co-writing and publication, and so on and so forth. Just like in the study that I showed, like we collaborate with the team from RSCM, and we also work with Dr. Dian Kusuma in one of the publications. So the more multidisciplinary, the more centers involved, it will be a strong result. Thank you.
Thank you, Dr. Eva and Dr. Dian. Yes, Dr. Shea.
Well, first of all, I want to thank all the speakers and all the participants. I really enjoy each of the presentations. I think one of the common themes or common thread that I've heard is the prevalence of stigma. I think whether we are talking about health issues or women's health or mental health and higher education, I think like Ms. Anita mentioned in your talk, Dr. Evans as well, that it's not so much the lack of knowledge. Sometimes it's really the attitude, right? And it's the stigma that stop people from seeking help and receiving help. And so I thought perhaps one possible collaboration, one is obviously we can't really study health and mental health in isolation. These really go hand in hand. And I think it's very clear from our keynotes presentations today. So it's one way to move forward is how can we maybe test a theoretical model in terms of reducing stigma. And I believe this model, such a model can be very broadly applicable to our students or even beyond higher education context. And then we can see how this stigma reduction may promote people's awareness of physical health and mental health, and also promote their help-seeking behavior.
Right. Thank you, Dr. Shea.
Okay. So I will add a little bit.
Yeah.
So from my point of view, I'm interested in the non-biomedical stakeholders, actually, because in fact, from the data, our people mostly access them. So it is important to move transdisciplinary or multidisciplinary, also understanding the non-biomedical stakeholders to tackle the mental health issue, actually, if we want to join and collaborate with them. That's my perspective. Thank you.
Okay, thank you, Bu Anita. Pak Evans, do you have anything to add to the group?
Yes, I think everyone have shared very important points. As I have shared in my presentation, the most challenging part is to be able to communicate, to share our knowledge. And I am glad that this event, this platform, we can listen and we can communicate and share. And maybe as Prof. Johanna already mentioned, that yeah, we have to have this kind of platform and maybe other platform that we can use to share our knowledge to each other, to the different areas and fields of the discipline different than us, and so we can build collaboration from that. Thank you.
Thank you, Pak Evans. So, Dr. Chitra, how's...
Thank you. Yes. So that is the aspiration that we can move forward in terms of being more connected, throughout the different institutions, the different fields of work, fields of study, and move forward, because this is a very important issue that we are working towards together to build well-being from the different angles, because it's overall health for the different population groups as well as for the general population. Thank you.
Okay, thank you, Dr. Chitra. Okay, so any participants want to ask our speakers anything? You can put them in the chat box or raise your hand. Well, while we wait for some participants maybe thinking about what they want to ask, I'm actually very interested. Oh, we have Arthur Rizan. Okay. Hello. Okay, thank you for your question in the chat box. I will read them out. A question for Mr. Evans Gary or Bu Anita. Some people with stress or some type of not so serious mental illness admit that they are feeling better after seeing a pastor or a dukun or something with gift. In your opinion, is this really true? And do you think the people that admit that they're healed really healed? And another question, in your opinion, what is the best form of medication for this type of sickness? Is it informal or formal? Is it best to go to a doctor or a priest? Okay, thank you for your question. So I think this can apply to anyone in this forum, really. But I will give a chance for Pak Evans or Bu Anita to answer this question first.
Yeah, thank you, Pak Arthur, for your question. Yeah, I think your question is a reality here in Indonesia. Maybe I don't know if it's applied. Maybe it's applied also in the United States. I don't know, in the UK or any other European countries. I think Anita, in her presentation, she already mentioned that we need to have a collaboration between traditional and biomedicinal. Would you kindly, maybe Anita, talk about that a little bit more?
Yeah, I think I don't try to define which is more effective, but I want to deliver a message that in certain contexts, the informal help, more access rather than formal help, there are several reasons, such as the shortage of the mental health workers and mental health services, and then the flexible in payment, and then the similarity about the value and concept. Also, stigma play roles in this issue, and the mental health literacy. There are several reasons actually. So that's why I'm really concerned about what is the perspective from non-biomedical stakeholders to able to join and collaborate to tackle this issue. So is it possible? This is actually my question. I still don't have answer. Is it possible to collaborate with the community gatekeepers, such as religious leader, traditional healer, or community leader, to train them to assist people? To what extent actually the situation need to revert to specialist group, and to what extent that distress could be treated by another stakeholders. I mean, outside the biomedical systems. So actually, this is also my personal questions: to what extent the distress have to treat it by the biomedical system, and also how to collaborate with non-biomedical stakeholders to tackle these issues. Sorry if this is not directly answer your questions, but from my presentation, I just want to show that that's the fact in our field. So they access and they feel better. So I think this is a different paradigm then. That's my response actually. Maybe another expert here have another opinion. Thank you.
Okay, thank you, Pak Evans or Bu Anita. Does anyone in this forum want to jump in? Okay, Michelle.
Yeah, maybe I would just add a little bit to it. I think this is an excellent question. When we consider mental health, there's the objective aspect to it, and there's also the subjective aspect to it. So when a person is sharing with us that they feel better, right, after seeing a pastor, a priest, or a healer, a traditional healer, I think first of all it's important to validate their experience and help us to also learn what make them feel better. But I very much agree with what Mr. Evans and Ms. Anita shared, that there's also, I think that it's important to look at the connection between the informal and formal support, because the informal support can serve as a potential referral resources. And I think if the person continue to experience these symptoms and distress, then we can also explain that, well, just like if you catch a cold, if you get the medication from the pharmacy and you don't get better, you might need to see a professional. And so perhaps that's the time that when you need to consider another option in addition to the healers, the priest, and the pastor. So I would probably offer to the person that these are all good options and feasible options, and just see them as like a web of care, web of support. And so that might be, I think, more acceptable to someone who either have a stigma towards seeing a professional or may not understand the process of seeing a professional.
Right. Thank you, Michelle. Okay, so Pak Arthur, I hope our experts have answered your questions. And looking at the time, I think it's about time I have to wrap this event. So I hope all of us learned something new today and leave inspired in our respective discipline. I urge all participants to reflect on what we learned about mental health, about global health and well-being, and how it impacts our environment as a whole. And at the end of the day, I think we cannot fix problems alone. And the key to innovation and progress is a multidisciplinary approach. So thank you for Prof. Johanna, Dr. Dian, Pak Evans, Bu Anita, Dr. Shea, and Dr. Eva for your time and expertise in this event. We look forward to future events with you and also maybe future collaborations. Okay, before we close, I invite speakers to say their final remarks. First, Prof. Johanna, do you have any final remarks or end note for our participants today?
Yeah, almost. Thank you very much for inviting me to speak first, because Dr. Shi is still at 3:30 in the morning. So I took care of your sleepy time. Thank you. And what I presented today is more practical, rather than almost all of the other speakers are talking about scientific research finding. But I guess the balance between the practical and the theoretical background is good. Thank you very much.
Okay, Pak Dian.
Thank you very much for the opportunity again, and thank you very much for the chance to connect here. So hopefully, as we discuss, hopefully there will be future collaboration with UKRIDA, including maybe the faculty or researchers and also potentially students as well. Looking forward. Thank you.
Thank you, Padian. And for Paivans and Bu Anita.
Yeah, just thank you everyone. Thank you for the participants, all the participants to discuss and to listen to us. Thank you, Bonita.
Yes, thank you for this opportunity, and I'll also learn a lot from other speakers tonight, and hope looking forward for the further collaboration. Thank you, everyone.
Okay. I invite Dr. Shea to give her final remarks.
Yeah, I echo everyone's sentiments. Thank you so much for this opportunity. It's really good to be here, seeing some familiar faces again, and I look forward to future collaborations, and hopefully I will get to visit your university very soon.
Thank you, Dr. Shea. And last but not least, Dr. Eva.
So yeah, thank you so much, Dr. Chitra and Dr. Jody, for arranging like this very nice webinar, bringing all together from different expert and disciplines on global health. This is a very important topics. Unfortunately, there's still a lot of stigma in the population, and hopefully we can work together from teaching, research together to overcome this and reaching a better mental health especially in Indonesia and worldwide. Thank you.
Thank you, Dr. Eva. Okay, now I would like to ask participants to fill in our evaluation form with this QR code and let us know what you think. Okay. So in the meantime, I would like to say thank you to all of our speakers for today. Prof. Joe, Dr. Dian, Pak Evans, Bu Anita, Dr. Shea, Dr. Eva. Terima kasih banyak. Thank you very much for being here. It was very great to meet you all. Thank you for your time. We really appreciate this. And we really learn a lot from all of you. So thank you.
Thank you.
Happy birthday,
Bye.
UKRIDA.
Happy birthday, UKRIDA. So thank you, participants, for being with us till the end of the event. You may leave this Zoom meeting after you scan our evaluation code, and I would like to invite everyone to our next event on September 7th. This is the next of the talk show series on philosophy of anti-aging medicine from womb to. So we have speakers that will talk about food and energy, cosmetic beauty, preventive beauty, and nutraceuticals for skin. So for those of you who are interested, you can register using the QR code or through our website at UKRIDA.
Yes, it is a part of a four series of events. So this is the next one next week on Thursday, and then after that we have climate change on the next Thursday, and then after at the very end it's personality and human relations. We'll have an interactive session with all of the participants. So thank you, everyone.
Thank you, everyone. Remember to fill in our evaluation form, and your certificates will be sent after you submit the evaluation form. So please make sure you do that.